Hello, my name's Daniel Parker. I'm a geriatrician and memory disorder specialist. I see patients at the Duke Memory Disorders Clinic, and today we're going to go over some of the basics of dementia. So in this talk, we're going to talk about what changes in memory and thinking are part of what we call normal aging, and what changes are concerning. We're also going to talk about how we define mild cognitive impairment, or MCI, and dementia. We're going to talk about the diseases that cause mild cognitive impairment and dementia. And we're going to, is that okay? And we're going to talk about, we're also going to review some exciting evidence that mild cognitive impairment and dementia may be preventable. And then finally, we're going to go over what happens at a memory clinic evaluation and how we make a diagnosis of mild cognitive impairment and dementia. So memory and thinking change with age. With normal aging, we can see sometimes that people may make a bad decision every once in a while. They may miss a bill payment occasionally. They may sometimes forget which day it is, but remember later on. They sometimes forget which word they're using when they're speaking. And they may lose things from time to time. These are all considered changes that are part of normal aging and nothing to be concerned about. However, changes that are concerning are when people are making poor judgments or poor decisions frequently. They may have problems taking care of monthly bills, missing multiple payments. They may also lose track of the time, date, or time of year, have trouble having a conversation, or misplacing things frequently and not being able to find them at all. These are concerning changes that you should talk to your doctor about to see if you should have a memory evaluation. Now that we've talked about the changes in memory and thinking that distinguish normal aging from something more concerning, I'd like to review some common scenarios that I see in clinic with my patients. Sometimes patients will start having changes, like they forget to pay their bills or they get lost going to a familiar location. They may forget a doctor's appointment when they've always been very good about going to all their appointments. These changes could be red flags that there's something more serious going on that should warrant evaluation. When I'm reviewing my patients' records before a visit, I often see that they've reported some changes to their primary care doctor up to a year before they actually got the referral to come to the memory clinic. So it's important that if you've noticed these changes in yourself or in a loved one, that you request a memory evaluation so that we can get to the bottom of what's going on with your symptoms and see if there are things we can do to help improve your memory and thinking. Now I'm going to move on to define some terms that we'll be using throughout the rest of this presentation. So the first term is subjective cognitive impairment. Subjective cognitive impairment is when a person notices subtle changes in their own memory or thinking that other people do not pick up on. If that person undergoes a cognitive evaluation, the cognitive evaluation is normal. And these changes do not interfere with that person's day-to-day life. They can still work, manage their household, manage their medications, pay their bills, etc. Now, mild cognitive impairment is when changes become a little bit more prominent. And not only the patient identifies these changes, but family members and friends may notice these changes as well. However, in mild cognitive impairment, these changes are not to the point where they interfere with this person's day-to-day activities. A person can still work, manage their household, pay their bills. They may make a few errors, or it may take them a bit longer, but they're able to handle these tasks independently. Now, if these changes get to the point where that person needs extra assistance with some of these day-to-day activities, then we say that person has dementia. So you can think about subjective cognitive impairment, mild cognitive impairment, and dementia as a continuum or a spectrum, where changes in memory and thinking get worse, and the impact of those changes in memory and thinking on that person's day-to-day function get worse as well. So MCI and dementia are umbrella terms. What do I mean by that? So they're words that describe a syndrome, which is a group of symptoms that occur together. And they don't necessarily tell us what's going on in the brain that causes those symptoms. And there are several different diseases that cause mild cognitive impairment and dementia. Now, the most common cause of mild cognitive impairment and dementia is Alzheimer's disease. Alzheimer's disease accounts for about 60% of cases of mild cognitive impairment that progresses to dementia and dementia. There are other less common causes of dementia, like frontotemporal dementia, Lewy body dementia, and then vascular changes like a stroke that can cause vascular dementia. Alzheimer's disease is the most common cause of dementia. The leading hypothesis for the cause of Alzheimer's disease is called the amyloid cascade hypothesis. In this hypothesis, changes in a protein called amyloid beta lead to it building up in the brain. There are genetic risk factors that can predispose people to these changes, most commonly the ApoE gene, which certain variants can increase the risk of developing Alzheimer's disease dementia. Now, as amyloid beta builds up in the brain, it triggers the buildup of another protein called tau. As tau builds up, it causes damage to neurons, leading to those neurons to die. And as this happens, people develop what we call neurodegeneration in their brain. And it's this neurodegeneration that leads to the symptoms of changes in memory and thinking that we pick up clinically when we do a memory clinic evaluation. Now, Alzheimer's disease is, as our population ages, the number of people living with Alzheimer's disease is expected to increase. As of now, Alzheimer's disease is present in about 10% of older adults age 65 or above, and it's the 6th leading cause of death in the United States, although this is probably an undercount, as many times Alzheimer's disease is not indicated as the cause of death. Caring for people with Alzheimer's disease is expensive, costing an estimated $200 billion per year, and this doesn't include the costs that are borne by family and caregivers to care for that person living with dementia. We also know that Alzheimer's disease affects women more commonly. This is probably due to their longer life expectancy. And there are also significant racial disparities in Alzheimer's disease. African Americans have a 2 times greater risk of developing dementia and Alzheimer's disease compared to white Americans, and Hispanic Americans have a 1.5 times increased risk compared to white Americans. But maybe there's some good news. As I mentioned before, as our population ages, there are more people who are living with mild cognitive impairment and dementia. However, the number of people who are being diagnosed with mild cognitive impairment and dementia may be decreasing over time. This is probably due to greater educational achievement in older adults and also better treatment of cardiovascular risk factors for dementia. There's also evidence that up to 40% of dementia cases may actually be preventable. So this is a report from the Lancet Commission, which looked at modifiable risk factors for dementia. These are risk factors that we could potentially do something about to reduce someone's chances of developing dementia. And they broke these down based on when in the life course they lead to an increased risk. So we know that people who have more educational attainment, more years of schooling, have a lower risk of developing dementia. There's also good evidence that treating hearing and vision impairment, decreasing the incidence of traumatic brain injury, treating high blood pressure, reducing alcohol use, and maintaining a healthy weight during midlife can also decrease the risk of dementia. In later life, quitting smoking, treating depression, remaining socially engaged, physically active, avoiding exposure to air pollution, and treating diabetes may also decrease the risk of developing dementia. So now I'm going to review what happens at a memory clinic evaluation. At a memory clinic evaluation, we obtain a history of the changes in memory and thinking from the patient, and oftentimes a loved one or trusted friend. We perform a cognitive assessment and a neurological examination to look at the areas of memory and thinking where that person is having challenges. We look at other factors that may be contributing to cognitive symptoms that we could potentially do something about. We obtain brain imaging, most commonly an MRI, and we consider additional testing to determine if the causes of their memory and thinking changes are due to something like Alzheimer's disease. And then finally, we develop a treatment plan to help address their symptoms. So in addition to talking about what happens at a memory clinic evaluation, I'd like to give you some tips to make your visit as successful as possible. If you can, bring a family member or trusted friend who's notice some of the changes in memory and thinking that you're experiencing. Bring a list of all the medications you're taking, and bring a list of all the medications you're taking, and bring any additional medical records of cognitive evaluations or other testing that you've had to the visit. If you've had any other brain imaging, it's important to bring an actual copy of the imaging with you to clinic so that we can review it personally. Now, other factors can contribute to changes in memory and thinking. These include things like depression and anxiety. And this can be a little tricky because sometimes as people are developing changes in memory and thinking as a part of Alzheimer's disease, they may also develop depression and anxiety. This is due to the disease itself, not because the depression and anxiety are causing the changes in the brain. We also evaluate the person's sleep to see if they have sleep apnea or insomnia, because we know untreated sleep apnea can make memory and thinking worse. We also look to see if they have any evidence of hearing impairment or visual impairment. There's good evidence that if people have hearing impairment, that they have an increased risk of dementia, and if they use hearing aids, that can actually reduce their risk. And there's also some recent evidence that if people have cataracts and have those treated, that can actually also reduce their risk of developing dementia. Another big thing we look at are medications. There are many medications that can negatively affect memory and thinking. These include anticholinergic medications such as Benadryl, amitriptyline, and others. These also include sedatives, things like muscle relaxants and benzodiazepines, as well as drugs that are used for sleep, like Ambien. All of these drugs can negatively affect memory and thinking. In patients with risk factors, we also may check for the presence of infectious diseases like HIV or syphilis. We also look for other medical problems that can lead to changes in memory and thinking. Patients with heart failure, liver disease, or kidney disease are at increased risk of changes in memory and thinking as part of those diseases. We also check vitamin status like vitamin B12, and then look at lifestyle factors like alcohol and tobacco use, as well as physical activity or exercise. How do we arrive at a clinical diagnosis? Well, we take all the information that we've collected through the visit, which includes the history of changes in memory and thinking, the results of our cognitive assessment, and also our assessment of how those changes in memory and thinking affect that person's function. Now, as I mentioned before, in subjective cognitive impairment, only the patient notices their changes in memory and thinking, and everything else is normal. In mild cognitive impairment, the patient has symptoms of changes in memory and thinking. We can pick those changes up on our cognitive assessment, but those changes aren't to the point where they're interfering with that person's day-to-day function. And then finally, in dementia, patients and families notice the changes in memory and thinking. We pick up those changes on the cognitive assessment, and those changes also interfere with that person's day-to-day function. They need a little bit of extra help with some of these activities. And so putting all that together, we arrive at a diagnosis of either subjective cognitive impairment, mild cognitive impairment, or dementia. We also routinely get brain imaging in patients who are presenting with changes in memory and thinking. Most commonly, this is an MRI of the brain. Now, we mainly use this to exclude other things that could be contributing to changes in memory and thinking. For example, mini strokes. Oftentimes, the MRI is normal in patients who have mild cognitive impairment or dementia. And there are some other specialized types of brain imaging that can be used to see if the changes in memory and thinking are due to something like Alzheimer's disease. These include things like FDG PET or amyloid PET. However, these are typically used in research settings, and we do not routinely obtain these in our clinic. Now, we do have the ability in our clinic to do some advanced diagnostic testing to determine if the changes in memory and thinking are due to Alzheimer's disease or a different disease that causes dementia. For Alzheimer's disease, we have the ability to do a lumbar puncture or spinal tap, where we collect a small amount of cerebrospinal fluid and check it for evidence of Alzheimer's disease proteins. We also recently started offering a blood test, which checks for Alzheimer's disease proteins in the blood. However, this is not yet covered by insurance, and the list price is $1,250. We can also do genetic testing to look for the ApoE gene, which, as I mentioned before, is the biggest risk factor for Alzheimer's disease that develops later in life. For Lewy body disease, which is another disease that can cause dementia, we can do a skin biopsy to check for the abnormal alpha-synuclein protein that builds up in Lewy body disease. And for frontotemporal dementia, we can do genetic testing to see if the individual carries specific variants that are associated with frontotemporal dementia. Now, one last thing I'd like to mention is something about staging. I'm often asked by patients after receiving a diagnosis, what stage am I, or how long do I have? I think it's important to remember that everyone living with dementia is very different. Some people have changes in memory and thinking that occur more quickly than others, and some people have changes that occur very slowly over time. And it's important to remember that even in patients with dementia, the vast majority of them will actually remain at home, living with their family and friends for the remainder of their life. Only about 15% of patients with dementia will actually end up in a nursing home. So everyone's different with this disease, and there are a lot of things that you can do if you have this disease to maintain your function and keep your brain working its best. So although we've achieved tremendous progress in the past 10 years with being able to diagnose changes in memory and thinking, and also understand the biology of Alzheimer's disease and related dementias, there's still a lot of stigma in the community for people who are living with these changes. And so it's important to note that if you're experiencing these changes or a loved one is experiencing these changes, that it's common. Many older adults struggle with changes in memory and thinking as they get older. And it's also important to remember that you need to get evaluated. If we do an evaluation, we oftentimes pick up on things that we can do to help improve changes in memory and thinking, in addition to seeing if the changes are due to something like Alzheimer's disease. If you or a loved one are experiencing changes in memory and thinking, I encourage you to speak to your primary care doctor about these changes. They can do an evaluation in their clinic and determine if you would benefit from a referral to a memory care specialist. So today we went over the basics of dementia, Alzheimer's disease, and what happens at a memory clinic evaluation. We talked about Alzheimer's disease, which is the most common cause of progressive mild cognitive impairment and dementia. We talked about modifiable risk factors that can reduce the risk of developing dementia, like treating hearing impairment, high blood pressure, vision impairment, getting regular exercise, maintaining a healthy weight, and making sure diabetes is adequately treated. We talked about imaging that we use to help us diagnose changes in memory and thinking, most commonly an MRI of the brain. We also talked about recent advancements in diagnostic testing, either with a lumbar puncture, blood test, or skin biopsy that can help us diagnose the cause of the changes in memory and thinking. And we reviewed the issues around staging and how staging is oftentimes not helpful in thinking about changes in memory and thinking and dementia. I hope this has been an informative lecture, and if you have any questions, don't hesitate to reach out to me. My email will be available as part of this presentation.